This video is for education and entertainment purposes only. Please consult with your healthcare provider before making any changes to your health plan.
Hey beautiful soul, it's Jacqueline from the Las Labia Chronicles in partnership with Lichen Sclerosus Support Network. If you have lichen sclerosus and are looking to empower yourself with information, find acceptance, and reclaim your life, then please subscribe to our channel and keep on watching. And if you have a friend, family member, or loved one with lichen sclerosus and you want to learn more about the physical and mental health aspects of living with lichen sclerosus so that you can better support them in their journey, then keep on watching and please share this channel with them as well. Alright, so in today's video, we are going to be talking about adjunct therapy. Specifically, we are going to be chatting about a hot topic in the LS community, which is laser therapy for lichen sclerosus. So I'm going to be chatting to you about what adjunct therapy is, what laser is, what the procedure involves, how much does it cost, how often do you want to go, and ultimately, what does the science say about laser for lichen sclerosus? Now, this is actually going to be a two-part video because what we often see out there with discussions with laser and lichen sclerosus are very kind of narrow discussions. But the truth is that laser, the topic of laser and lichen sclerosus is actually way more complex and nuanced than people think. So there are different types of laser and that matters. So there are ablative lasers and non-ablative lasers. Those are like the two main categories, and then underneath those there's like a bunch of other little subtypes. So for today's video, we're going to be focusing on ablative laser, and then in a couple of weeks from now, I'll be back here to chat about non-ablative lasers. As always, if you find the information in this video helpful, please give us a like, please subscribe, and if you feel so compelled, please consider making a donation so that we can continue creating educational support for lichen sclerosus. Before we start chatting about laser specifically, I just want to get some terminology out of the way, and that's the difference between a primary treatment and an adjunct therapy. So your primary treatment is used to treat and manage your lichen sclerosus. The primary treatment is the treatment that has the most reliable and robust evidence behind it as an effective treatment. And it also, in the context of the scientific literature, has the highest success rates. So that's your primary treatment. You might also hear that as like the gold standard. This is typically the first treatment that your doctor will try you on because it has so much evidence behind it in terms of efficacy, safety, and success. Now, an adjunct therapy is something that may not have evidence for in terms of it actually being a treatment, but there are still some benefits that people see, and you can kind of stack it onto or think of it as an add-on to your primary treatment to really just boost the effects and get the most improvement in terms of symptoms, quality of life, sexual health, all of that. So those are the two main differences. Again, your adjunct therapy is an add-on. It's not meant to be the primary treatment, but used in conjunction with a primary treatment can often be quite fruitful for lots of folks. So let's chat about laser for a split second here. So we're chatting about ablative laser today, right? And so I want to talk to you about what that kind of entails. So ablative laser uses this kind of cone beam of energy. It's often going to be a little handheld device that your clinician will use, and that beam of energy essentially does two main things. The first thing it does is that it destroys or removes the top layer of skin. That top layer of skin is known as the epidermis. It's the most top layer of the skin. So first it removes that. Second, underneath that, you have a layer of skin called the dermis. Think of that as like the kind of middle layer. Now, that cone of beam heats up that middle layer. So it's both destroying the top layer and then heating the layers underneath. At least those kind of mid layers is what it's doing. And allegedly, this combination of heat and, ablative removing of the top therapy stimulates collagen and elastin and promotes your body's kind of natural healing process. Now, if you're sitting there thinking, wait, hold up. You are essentially like destroying and removing and burning off that top layer of skin. That sounds incredibly painful. No way do I want to put my vulva through that. I'm already in pain or uncomfortable. Thank you, but no thank you. If you're thinking that, you are definitely not alone. So let's chat about, is this painful, and what is kind of done to mitigate or reduce some of that pain and discomfort. So first things first, when your clinician uses laser on the vulva, they will use a topical numbing cream first to help reduce that kind of pain sensation. So again, topical essentially is something that you're going to put on the skin. So it's a cream or an ointment, something like that, and then it numbs the skin so that you don't feel it as much. So right now they've got nothing on my skin. I can feel this very easily, but if my skin was, had that numbing agent, I would feel this slightly less, not slightly less, significantly less, right? I might still feel a little bit of pitter patter, but I'm not going to feel it as intensely. So they do use a numbing agent. Now, in the literature, most of the reports that I see say that the procedure itself is kind of either mildly uncomfortable, some people report discomfort, and a heating sensation. Now, the heating sensation absolutely makes sense, right? If we remember that part of this two-part thing that the laser is doing is it's removing, it's heating that middle layer. So that heat type sensation does make sense. Anecdotally, it's a mixed bag. When I say anecdotally, I just mean what have I heard from people in the community? It's all over the place. So I've heard some people say I could take a nap while my clinician does my laser. I feel nothing. I am just so relaxed. It's a little spa treatment. So I've heard anything from that to I was crying through the whole session and it was excruciating. And then there's anywhere in the middle, right? So, maybe not a super walk in the park and I was taking a little nap, but also not, excruciating. So it was painful. I had some parts that hurt more, some parts that hurt less. But suffice it to say, we're kind of sitting in the middle. And that kind of mixed bag response really makes sense because the truth is that pain in the body is experienced differently for each and every person. So what might seem excruciating to me could be just a mild discomfort or a little annoyance for you, right? And that's not to invalidate my experience or even your experiences. Both are valid. Just the ways that bodies process pain differs from person to person. So it does make sense that, everyone does have a different experience. And I would say that if you tend to know that you have a low pain tolerance or that you tend to be quite reactive to pain stimulus, I would communicate that with the clinician beforehand and, just see what options they may have for you. There may be a different topical numbing cream that they could give you. They might not go as hard, well, not hard, but they may do less for the first round or something like that. But I definitely think it merits a discussion and that the clinician should know about that. Post-procedure, there is usually some mild discomfort reported, sometimes a little bit of pain. According to the studies, they will say that this pain and discomfort is well managed with a combination of acetaminophen, which really, depending on your country, could be paracetamol, Tylenol, etc., and ibuprofen, which is Advil in my country, but might be something different in your country. So usually it's a combination of those two, and then ice, perineal ice packs that can usually help, for 2 to 3 days, and then the pain and discomfort just kind of peters off. That said, again, everybody is different, and I have heard reports of people saying that they were in quite a lot of pain for at least 2 weeks after. And then I've heard people that told me yeah, I was totally fine. Like I didn't need any Tylenol, any ibuprofen. I didn't even need to ice. I just went straight to work, and then I went to the movies with my friends after, and I was totally fine, right? But for me, I think it's just important that folks kind of know all the information up front, and then you manage it according to your body and how comfortable or uncomfortable you feel. Another thing that you might want to consider is how you dress the day on of your appointment and how you dress a couple of days after, especially if you do experience some mild discomfort. So when I talk about how you dress, I'm really just referring to underwear and whatever bottoms you're wearing. So in terms of underwear, I think that either going commando or wearing a pair of loose, gentle cotton underwear would be preferable, just so you don't have stuff like kind of, like I'm thinking like a tight lacy thong that's kind of like rubbing against the vulvar skin. Remember, you just got that first layer of skin removed, right? So you probably don't want something aggressively rubbing against it. So something very loose and comfortable. Same thing, pants, skirt, just make sure they're kind of loose and not super tight fitting to just avoid friction on that area just for the first few days after, and then you can kind of bring back whatever bottoms you usually wear afterwards. So those are kind of, some tips and tricks for kind of the day of. And then the last thing I'll talk about for, what does this involve and what should you kind of do prep-wise. So in addition to having Tylenol, Advil, ice packs, comfortable clothes, there's one more piece to address, which is getting home. Do you need to have a driver pick you up, or can you just go home? This, truthfully, again, is an individual case by case basis. So some folks are like, oh yeah, I just drove myself back to work, or I just drove myself home, or I took the public transit, no problems. And some people just opt to have a friend or family member pick them up. I would say that, again, if you're concerned, if you have any concerns, at least for the first session, right? Because at the first session, then you'll kind of get an understanding of what this is going to be like for you for future sessions. But the first session, you don't really know. So maybe for that first session, you ask a friend or family member, or maybe even just schedule an Uber or a taxi or something like that to bring you home. And then, of course, if you were like, oh, you know what, I could have totally just taken the bus home, then cool, you know that for next time, and that will be your plan moving forward. So what does laser cost? What's the cost, and how often do I have to go? So both cost and frequency are determined on a case-by-case basis. So costs can depend on a multitude of factors, some of which include where you live in the world, the clinic's pricing structure, whether you have insurance, and then whether insurance will cover some or all of the procedure. So again, these are some variables. I live in Canada, and the average price that I see for one session is about $1,000. That can vary, so I've definitely seen clinics offering it lower, and I've also seen clinics offering it a bit higher. So that's just to give you a kind of ballpark range, but the best way to know is really just contact the clinic with the laser and ask them, what a session would cost, or if they can give an average. They may need to see you. They may ask that you come in for a consultation so that they can really determine how much surface area, if that's how they do their pricing. But again, that's just to give you a little idea. Now, in terms of frequency, this will depend on two factors. So one is how severe is the case, how severe is the lichen sclerosus, and the second factor is going to be how your body responds to the laser sessions. Now, what I typically seem to see is anywhere from 3 to 6 sessions up front. Those are done pretty regularly. And then after that, then it's 1 or 2 sessions per year as maintenance. Now, if you're like, wait, what, maintenance? I need maintenance with laser too? Yes. Unfortunately, at the time that I film this, there is no cure for lichen sclerosus. And lichen sclerosus is progressive, which means that there does need to be a constant treating of the lichen sclerosus, at least until we find a cure, and then we don't have to worry about it. But if you are thinking of swapping over to laser so that you don't have to do any maintenance work, unfortunately, that's not the case. You will still need maintenance laser sessions. They will be less than what you need in the beginning, of course. There's going to be more sessions in the beginning, but again, Now, the other thing is that if your doctor says laser is a cure for lichen sclerosus, I would respectfully ask them to show the studies that they have supporting and showing that laser is in fact a cure for lichen sclerosus. At the time that I film this, I have never seen this. I don't think they'll be able to provide that. So usually that's a little bit of a red flag for me when they tout it as a cure, but that's just a personal thing. So that aside, yes, maintenance therapies are required. So frequency, again, case by case, and will be a long-term thing, even though you will do it less frequently as you move forward. What does the science say about laser? Is it a treatment? Is it an adjunct? Is it effective as either or? What's the deal? Is it worth your money? We're going to dive a little bit into what the science says. Now, two things. This is going to be a more informal chat about the science. If you're kind of a science geek like me and you want to go a little bit more the formal route, there will be a blog post on this for you to check out. But for this purposes, we're just going to keep it casual, keep it simple. The other thing I want to flag here is that this is my interpretation of the science. Other people's interpretations may differ. So please take that, as you will. Be sure to always do your own research. I am not the be all end all of, interpreting this. So, always feel like that's important to say. Next, we're going to start with, under the category of ablative lasers, we're going to start with the most popular, which is a CO2 laser. If you've never heard of that, I'm sure you know CO2 lasers because the kind of, mainstream name, or the most popular, if you will, laser is the Mona Lisa laser. So the Mona Lisa laser is actually a CO2 laser, and that's the one that we're going to start with. Now, there's actually not too many studies done on laser compared to other things like steroids, right? So I don't have as much to draw on, but we're just going to draw on a couple studies here to start. The first study that I want to highlight is a study by Balchander et al. It was published in 2020 and looked at 40 people with vulvar lichen sclerosus who were not responsive to topical corticosteroids. So when we look at this study, basically these 40 people all got the laser treatment, and it was reported that about 70% of them saw an improvement in their symptoms. In terms of how the skin looked, there was also some minor improvements, specifically with hypopigmentation. And again, hypopigmentation is just when the skin becomes lighter and lighter, it kind of loses its pigment. So some of that loss of pigmentation came back. That was reported around 20% improvement. So at face value, we might be thinking, well, that's really good, right? I mean, it's pretty rare to see a study looking at a treatment or intervention that has 100% of participants saying 100% improvement, it's perfect, everything is great, right? So we might be thinking, well, 70% is almost 3/4, that's a pretty good outcome, right? And yeah, on the face of it, it is. Unfortunately, this study was not the most reliable of studies, so they didn't really have any methods in place to filter out bias or kind of mistakes or anything like that, which means that we kind of just take it at face value. It's kind of hard to know if we can trust those results or not because they didn't really have any methods in place to help create reliable results. So with that, we're going to look at a second study, which was done by Mitchell et al. In 2021. So in contrast to the Balchander et al., the Mitchell 2021 paper is a very, very, very well-researched paper. They used a lot of methods to ensure that the conclusions that they drew were actually reliable. These methods help to filter out bias and other kind of things that can impact the quality of the results and the trustworthiness of the results. So for example, this study was randomized. There was 40 people as well, but there was 20 people in the group that got the real laser, and then there was 20 people that got the sham laser. So basically, it's like a fake laser. It's not really the real laser. Secondly, everybody in this study was blinded. Now, what that means is that neither the patient nor the clinician knew if they were giving or getting the real or the fake laser. This is really important when we talk about bias in science. And actually, the study wasn't really double-blinded, it was actually triple-blinded, because the dermatopathologist that was actually looking at the before and after biopsies from each group did not know whether the biopsies that they were comparing, they didn't know if they got the real or the sham laser. Again, just another way to kind of ensure that bias is being pushed out and that we can actually trust the results. Now, when we talk about a pre and post biopsy, this means that before any of the patients start treatment, they will get a biopsy to determine how much inflammation they have. And then after the real or fake laser, they do another biopsy. What they're looking for is that original biopsy. They want to see a statistically significant reduction in that inflammation. Why? Well, because the inflammation is really what is driving the majority of our symptoms, of our clinical signs. Everything to do with lichen sclerosis all boils down to that inflammation. Remember that lichen sclerosus is actually the single most inflammatory skin condition out there. Boatloads of inflammation. So to be considered a treatment, you want to see that inflammation go down quite a bit from the initial one. This is something that has been shown with things like topical corticosteroids, and that's why they're classed as a treatment and not an adjunct, because they actually have a ton of really credible, really good research behind them showing that decrease in inflammation. So what happened with the laser? Did the people that get the real laser, did they see that decrease in inflammation to show that yes, this can be a potential treatment? Unfortunately, no. There was no significant changes to the levels of inflammation in either of the groups, which the authors concluded that this means that laser, specifically again CO2 laser, is not an effective primary or mono treatment. So a mono treatment would be like that's the only treatment you're doing. You're not going to treat with anything else. You're only going to get laser. So they wouldn't recommend it for that because it doesn't have those kind of markers to establish it as a treatment. It's not doing what we need it to do to be classified as a treatment. And then a primary treatment, they also don't recommend it for that for the same reason. Now, I want to give a really important caveat to this study, and that is the fact that despite it not showing that decrease of inflammation, many people in the study were saying, yeah, but I feel better, my symptoms feel better, or I think my skin looks better. And I just want to flag that because symptom management and feeling better is directly tied to our quality of life. And so I still think that that's valuable. And we're going to talk about that at the end of the video when we talk about, should you do laser or not? Is it worth it or not? Like, we're going to come back to that piece, but I just, from the get-go, I want to kind of validate that for folks that have had laser and they're hearing about the treatment thing. It's not a treatment, and they'll say, well, I feel better. And it's like, yes, a lot of people do, and that's great, and that has its place and does make it important. It's just about how we speak about it that matters. So I want to chat about another study in 2015 by Lee, Lim, and Fisher. This was a really interesting kind of case study report. So there's only 5 participants in this one, and these 5 people had something called refractory lichen sclerosus. Now, I did talk about this in the second session on Penny's podcast. So if you want to learn more about refractory lichen sclerosus, that would be a great place. I will link that in the description box below. But very quickly, refractory lichen sclerosus is lichen sclerosus that doesn't respond or improve with topical corticosteroids after 6 months to a year, and there are no secondary conditions responsible for this. The patient is using their medication in the proper way, consistently, etc. Then it's considered refractory. So these 5 people had refractory lichen sclerosus that was not responding to topical corticosteroids. So what these authors did was they set up this kind of, not study, but they had the 5 of them go, I said 5 and then I put up 10 fingers. 5 of them went and had these laser sessions, and they were using steroids at the same time. So this was a combo of laser and steroids. Now remember that they weren't reacting at first with just steroid. Now they're doing steroid and laser. And what they found was all 5 participants were then able to get into remission. And then once they were in remission, they no longer needed the laser. They were actually just able to maintain remission by using topical corticosteroids. So this suggests that maybe there could be a place for laser used in combination with like a primary treatment plan for people who are not kind of seeing the results that they want, they're not seeing their symptoms fully improve, or they have refractory lichen sclerosus. So that to me always stood out as a really interesting case study. And I've heard Dr. Jill Kraft talk about this, and her thought process is, instead of advocating for laser, which is not really accessible for most people because it's very expensive, not all clinics do it. It might, if you live in a really rural city, you might not have any clinics that have a laser, period, right? And so Dr. Kraft's perspective is we can achieve something similar to the laser by simply soaking in warm water. So this kind of comes back to, what is the laser doing? Ignore the removing of the epidermal layer, that top layer of skin that gets destroyed by the laser, ignore that. The second part is taking that dermis, which is that kind of middle layer. Now, for people with lichen sclerosus, that middle layer is characterized by significant thickening and hardening, which means that it's really hard for the steroid medication to get past that thick layer. It kind of gets jammed up at the top. We need it to go past that layer and then all the way to the bottom, which is that kind of source of inflammation. So by heating this layer with the laser, we're kind of softening that thickness and hardness and making it easier for the medication to get all the way to where it needs to go. But similar to the heating of that skin, when you soak in warm water, you're softening that skin again, making it easier for the medication to pass through and get to where it needs to go. And so soaking is definitely more accessible than laser for most people. Even if you don't have a bathtub, you can buy a sitz bath on Amazon for like probably $20-ish. Grain of salt that quote, because I haven't checked on Amazon in a hot minute, and it will depend on your country and all of that. But that would be way cheaper than multiple rounds of laser and then laser on a maintenance once or twice a year, right? So that's kind of her philosophy and perspective with that. So far we've actually been talking just about CO2 fractional laser, but I mentioned before that ablative lasers, there's different types. So I want us to move away from CO2 and we're going to talk about a YAG laser. It's called an erbium YAG laser. We're just going to call it the YAG laser to make it really, really simple. It is ablative, but it doesn't penetrate as deep as the CO2 laser. And that's another kind of nuance to the laser discussion, which is, there's different types. There's ablative, there's non-ablative, and then under each there's different types. And they all penetrate different depths, which again can be very important, especially because lichen sclerosus is a condition that it's not just the top layer, right? It affects all the layers of skin. So it is a skin deep kind of condition, if you will. So with YAG laser, there's not as much as there is in terms of studies compared to the CO2, but we still have, some case reports here and there. So I'm going to talk about a case report by Hobson et al., which was published in 2018, looking at 2 patients who were not responsive to topical corticosteroids. So the first was a 58-year-old person, and they were managing, but poorly managing. What their protocol looked like was actually triamcinolone intralesional injections and daily clobetasol. So I am going to have content on intralesional injections, when those are appropriate, when you might need to have that discussion, who does them, etc. But if you get to the case where your doctor is proposing intralesional injections, which is where they inject steroid into the vulva, it's usually when you're not responsive to the topical version. You may have a more severe case, or there may be a lot of thickening that they kind of need to get at before they can move you over to purely topical. So this person was doing both the injections of triamcinolone, and triamcinolone is a steroid, by the way, and daily clobetasol. So they did give this person the YAG laser treatments, and 1 year after kind of doing a combination of clobetasol and the occasional YAG therapy, this person saw great results and was able to just manage with topical clobetasol. So that very thick skin, those thick patches they were experiencing, those kind of went away. So this person definitely saw improvements when they combined clobetasol with the YAG laser. The second person was a 73-year-old person who was managing with clobetasol and lidocaine, topical lidocaine, I should say. If you're not familiar with what lidocaine is, it is essentially a topical, again, so something that you would, a cream, an ointment, a gel form that you would rub onto the skin. In this case, it would be the vulvar skin. And lidocaine, again, is a numbing agent. So what it does is it numbs the skin. So this means that this person probably had a lot of pain. Like, I don't know, they may have had itch, it wasn't really mentioned, but usually lidocaine, you think it's, it can be used for itch, but it's often prescribed when there's a lot of pain. So this person clearly had, a big pain component. They had a lot of scarring around the clitoris, around the entrance of the vagina. So they had a very severe, very aggressive case, and like the first person, they did a few rounds of the YAG laser, they continued using their steroid, and about 1 year afterwards, they were able to just use the topical to maintain, and they responded very well, again saw improvements to signs and symptoms. So what's the takeaway on this? Both patients seem to react pretty well to the YAG laser. So does that mean that YAG is a great treatment option for lichen sclerosus? Well, the truth is we don't really know. So in my opinion, what this kind of case study highlights is that there could be a role for YAG lasers, either as an adjunct or maybe a primary treatment. This case study alone does not show it as a primary treatment because it was not a controlled study, but also because they were using steroid at the same time. So for it to be a primary treatment, they would have had to treat the patients exclusively just with YAG laser and not allow any steroids to see if it actually had the same difference. Unfortunately, they were doing multiple things at the same time. So it's hard to know how much of the improvement was due to the YAG laser and how much was this due to something similar to the CO2 case study with Lim, Lee, and Fisher, who were, kind of using it to help break down that thickened skin to get the medication where it needed to go. Again, to me, what this says is we need more kind of randomized control studies on YAG laser to really, get more information, more than just, two people, because this is really just two people, right? We want more studies on this with bigger groups of people. So the verdict is still out. Could be something to explore as an add-on right now, but there's no evidence showing it as a treatment at the time that I am recording this. All right, so what's the verdict? Is laser a good treatment option? Well, to date, we don't have any studies that have proven or shown it to be an effective treatment, which means that most doctors are not going to recommend it as your primary treatment. That said, the evidence that we do have suggests that there may be a place for laser as an add-on or kind of adjunct therapy to your primary treatment to really get you to where you need to go, right? And again, a lot of those studies show that people that are getting laser feel better, right? They see improvements in their sexual health, they see improvements to how their skin looks, they see improvements with their symptoms. Even though it's not maybe doing the reduction of inflammation that we want, they are feeling better. And let me tell you, as somebody with lichen sclerosus who lived, for like 11 years with a lot of pain and distressing physical symptoms, symptom management is so important, and it's so intimately connected to our quality of life. And our quality of life matters, okay? Your quality of life matters. So if you need to tack this on to feel better, to see these improvements, then by all means, your body, your choice. This is just kind of coming at it from what the literature shows and kind of just being super transparent about what's out there so that you can make the best decision for your body. We are all about sharing evidence-based information out there so that you can make informed, consent-based decisions about what is best for your body. So that is it for this video. If you use laser, please share your experiences in the comments below, whether they're good, bad, or just kind of in the middle. If you have any questions, of course, as always, drop those in the comments section. If I can't answer them, I'll try to get an expert on here that can address them. So with that, that is it for this video. I will catch you in the next one.